Today, we're honored to be joined by Dr. Shashika Bandara. Dr. Bandara is a global health leader and advocate dedicated to advancing health equity and addressing systemic disparities in healthcare systems worldwide. Currently serving as a senior lecturer at Monash University Malaysia following his doctoral work at McGill University. His work focuses on challenging entrenched power structures in global health and promoting inclusive community-led approaches to policy and practice. He has collaborated with international organizations, researchers, and grassroots leaders, including his research leadership alongside the O'Neill-Lancet Commission on Racism, Structural Discrimination and Global Health, to drive meaningful change, particularly in low and middle income countries. Through his research, advocacy, and leadership, Dr. Bandara continues to push for a more equitable global health landscape, one where local voices are centered and sustainable solutions are prioritized.
I'm sure Dr. Bandara, Shashika, will tell us a lot more about himself during the presentation. But through his research, advocacy, and leadership, he's continued to push for a much more equitable global health landscape, one where local voices are centered and sustainable solutions are prioritized. Following the presentation, we'll host a live Q&A period, so feel free to drop any questions throughout today's webinars using the chat function.
Yeah, but without further ado, let's give a warm welcome to Dr. Bandara. Thank you so much for joining us today.
Brilliant. Thank you, Matthew and Jonathan, for all your organization efforts and also for this nice introduction. Okay, so today I'm going to talk about dismantling structures and shifting power, urgency of allyship in global health, recognizing that I'm speaking to an audience that might be largely based in Canada or in high-income countries, but for everyone, this is relevant. So let me start with sort of the environment I want to create. So I want, especially at the Q&A session, for you all to think about, as I go through this talk, think about your experiences and also be okay to be vulnerable, and think critically, examine intentions, and challenge even the ideas that I present and have a vibrant conversation. Okay. So what informs my positionality? I'm originally from Sri Lanka. It's a small island off the coast of India, and I grew up in a city called Kandy. Another factor of my positionality is that I grew up during a time of civil war. And so that has also fashioned my research interests as well as how I look at the world in terms of recognizing the importance of armed conflicts as it impacts global health. More on my positionality. So this is the Sri Lankan flag at the top left-hand corner. I did medical research at Hopkins University, but I also have done human rights and humanitarian work, both in the South Asian region. And I have done policy research at the Global Health Institute and McGill, where I completed my master's and doctoral research respectively, and I worked at both institutions, my post following my degree. So the fact it's necessary to recognize how the education institutes also affect the way we think and the way we view global health. And I'm currently at Monash University Malaysia, which is not on this slide actually. So I want to start with three facts. The first fact is that we are firmly immersed in a polycrisis, right? If you look at the news, every day you're seeing something related to whether it's an armed conflict, whether it's a bombing of, whether bombing of civilians or children, or whether it's the rising of temperature due to climate crisis. I know Montreal is at least going through some heat waves right now, and we also see other challenges such as of access to medicines or really difficult outbreaks. We are just facing an Ebola outbreak, which I think is getting under control right now. So the world is immersed in a polycrisis, and one of the major factors of this polycrisis is also the rising inequity in our society and in global health in particular as well. So that's fact one. Fact two is inequities and injustices in global health are at the root of this challenge. So this picture on the slide is the WHO report on social determinants of health in 2025, which talks about how health inequities are shortening lives by decades around the world. And these inequities are not just limited to low and middle income countries, these are also affecting high income countries as well. So it's highly necessary to recognize how inequities and injustices in global health are affecting our own health, our own communities, and we have to address these upstream factors rather than looking for silver bullet solutions. The third fact is that we, whether we are young, whether we are old, whether we are starting our careers or whether we are at the end of the careers or in a completely different career than global health, we all can do something about it, right? Audre Lorde wrote this book called Master's Tools Will Never Dismantle the Master's House. So a theme of this talk is power and dismantling structures. So it's highly necessary to recognize that some of the structures that we have right now will not allow us to meaningfully center equity in global health. I'll talk about this a bit more. So the goals for today, right? Let's learn about the history, challenges, and opportunities in global health, and let's also examine pathways how we can commit to shifting the status quo. Right? I'm a big fan of these funny comics, so here they are on the slides, and how I hope we will all feel at the end of the day. I hope we can achieve our goals and we can look like this, after this webinar. Okay, so. Can we all agree that every aspect of health is political, right? Whether we think about non-communicable diseases, whether we think about infectious diseases, whether we think about access to medicine, what do you all think? Is health political?
Yes, definitely. In terms of
Okay.
many different aspects, like funding or just what sorts of programs you have to treat these illnesses, etc.
Okay, brilliant. So I'm hoping the room agrees with Matthew, right? This is a piece that Dr. Tedros wrote, who is the outgoing head of the WHO. He wrote that health is a political choice. This was focused on non-communicable diseases, but he has also written many articles, especially around vaccine equity during COVID-19, how and on climate crisis, like how high-income countries need to commit to access, how the political factors are affecting equity in global health. So where we go from here requires us to know where we came from, right? So I'm going to jump into the history a little bit. Something about global health that not a lot of people tell us is that global health is rooted in colonial priorities and colonial interest. So if you can go and look at this article, which really nicely lays out the how the colonial priorities, academic ambitions, business opportunities, and geopolitics define and dictate how we think about global health. For an example, malaria, malaria research, malaria control was born out of the fact that the colonial entities wanted to protect their bottom line, meaning that they did not want the ones who they enslaved to get sick. They also didn't want the slavers who were controlling the enslaved population to get sick. And overall, they did not want their businesses to suffer. So a lot of these universities, whether it's London School of Hygiene and Tropical Medicine, whether it's Edinburgh University, whether it's McGill, right? They all have colonial roots. So in this article, which I just mentioned, talks about how malaria research was essentially shaped based on colonial interest. And also, as I just mentioned, a historical study of LSHTM from its origin, highlights the colonial roots. And then Edinburgh University had this really, it's a challenging report to read, but kudos to them for doing this report that looked at how they contributed to colonialism, not only colonialism, but also white supremacy, right? So these are organizations and universities that we look up to that still set the standard, and not just these two, but around the world. Like I mentioned, many universities that were founded in that era, all the big names, all the legacy names have these roots and have benefited from colonialism as well. And Lancet, I hope everybody knows on this call, the journal, one of the premier journals in global health, has this piece on. They commissioned this to look at how Lancet itself has contributed to colonialism. So many of the findings is that Lancet helped legitimize the field of tropical medicine. Lancet supported eugenics, if you know eugenics, which promotes sterilization, legislation of racial hygiene, compounded the benefit of colonization. So they benefited from it. They accumulated wealth, and situated English language as the standard language, which kind of sidelines many other knowledge production. And the influence that Lancet has right now stems largely from the times of colonialism. So these are the things that people won't talk to you about, but this is an article that is on the Lancet itself, which forces us to look at how this system has benefited from colonialism and how it's perpetuating colonial ideas as well. I want to briefly talk about experiments. If you haven't looked at Tuskegee experiment, which was a experiment in the U.S. that was commissioned by the U.S. government itself for treating syphilis, which was highly unethical because even after a treatment was found, these populations were not given the treatment, which led to many of the black population dying, the African American population, and then also it affected the children and the families as well. I highly recommend you read about this and recognize the unethical practices at the root of global health. A lot of the ethics foundations that we have right now in terms of how we do research has come as lessons of this experiment, but we still have unethical practices in global health. One of the things when I give this talk is that a lot of people after come and say, "Oh, a lot of these things are in the past. We are better now. We have moved forward." I don't think so, right? This BBC article, this was a big deal during COVID-19. Two French doctors went on national TV and said we should test the COVID-19 vaccine in Africa first, just like we do with HIV/AIDS vaccines, HIV/AIDS medication, and so on. This was on national TV in France, right? And for people to have that level of confidence, a normalizing of making these statements, kind of pushes us to, whether it's uncomfortable or not, pushes us to recognize how deeply these kind of ideas are in global health. There was a huge blowback for these comments, but even for these comments to be made, we have to take a look at ourselves, our field, and think, okay, where exactly are we in terms of countering colonial ideas, right? And just soon after Trump's election, there was an unethical vaccine trial, which is now canceled, on hepatitis B, on Guinea-Bissau, that RFK Jr. was pushing, which was again unethical because there were treatment available and it was affecting the population. And this was going to be done on children, right? Then most recently, the Ebola outbreak that is happening right now. US government wants to build a quarantine facility in Kenya so that the infected Americans won't have to come to the US. So these are the kind of colonial trends that we are still seeing in the world that somehow also, to an extent, is being normalized by leadership such as the US government at the moment. And the current models did not just appear, right? As I have spoken throughout, like it carries the flaws of the old. So if you look at this paper and this image on your screen, you see how different types of discrimination affect and uphold power and privilege in global health. So this is something to keep in mind as we also do global health. We also have to recognize, are we perpetuating through our own positionality, through our own work, many of these isms, many of these discriminatory practices and concepts in our work, right? So governance. So I'm going to talk about different sections first. So I'm first going to talk about governance. Does anyone know what this picture is about? Quickly.
Never seen it before. No.
Okay, take a guess. Take a quick guess.
Well, it kind of appears like a type of statue where we see some heads submerged, some are like above the water. So I kind of guess that represents like a power imbalance or something.
Okay, so this is a picture of world leaders discussing climate crisis while drowning in water. So, and this is Isaac Cordell who does this kind of sculptures, you're correct, around the world. And this shows how, even as we are drowning, how the governance, how our leaders continue to ignore the key aspects and uphold power, right? So this is actually the challenge we are facing right now. I hope you all have seen the movie Don't Look Up on Netflix as well. It's a comedy. I recommend you all watch it. It's also about climate crisis, right? And political inactivity. So governance is at a crossroads. So Madhupai from McGill University, who I used to work with, who I still work with actually, but who when I was at Montreal, we taught this class together on fundamentals of global health. And in 2022, he had this Venn diagram on your left. And, he had focused on economic inequity, leadership crisis, and three of the crises that we are facing. But you can see how by 2024, he had to add a lot more into the Venn diagram because the world was becoming more and more challenging and having more and more um, uh, um, uh, aspects of the polycrisis, right? If you draw this in 2027, I'm sure there's going to be a lot more as well. So this is the path we are on, and this is the challenge we have to face and address as well. So if you look at representation in global health, you can see there's a organization called Global Health 50/50 that looks at representation in global health. And in 2022, their report highlighted there's not a lot of representation in terms of low and middle income countries. Rarely women from low income countries lead boards, leadership positions in global health, and also in terms of gender. Um, Not a lot of queer communities are represented at the leadership of global health. So this was a status quo in global health, deep inequities, right, in terms of representation. So this also reflects when you make decisions about global health, whose interests get prioritized. If a lot of high income country people are at the board, as well-meaning as they may be, they may not completely understand the realities of low and middle-income countries, right? If a bunch of men are in the board of a global health organization, then they will not completely understand the health challenges of women and so on. So this is a key challenge in global health. So in 2025, they did this, they produce this report periodically. They say that, okay, in 2025, low and middle income country representation has increased. However, for the first time since their monitoring began, they documented regression across every core variable that they assessed. And this is also a reflection of the policy landscape shift in global health, right? We wrote this piece in conjunction with the 2022 report, and we said as emerging leaders at the time, at the time I was doing my PhD, as emerging leaders in global health, we're not prepared to stand by and inherit the status quo, right? So as young people on this call, I also ask you all to recognize these inequities and not stand by and inherit the status quo, right? You can read this piece at the link. I want to briefly highlight some governance failures from the recent past, just so that we are all grounded in this reality. One is, as we all know, vaccine inequity, right? Like how COVID-19 vaccines were not equally distributed, especially to low and middle income countries. You can see how the objective was not met on the chart on the right hand side, how upper middle income and high income countries met this goal, and how look at the low income country level. It's not even 10%, right? It's slightly about 10%. And then, in terms of climate crisis, when high income countries kind of set the standard, Trump set the standard, other countries follow, such as Indonesia, right? And then, we also know Argentina pulled back from the WHO, and Colombia might do the same with this new election. And then we also have armed conflict around the world, highest number of armed conflicts since World War II. And we also know how journalists, healthcare workers, children, especially, have been killed with impunity, without any consequences in Gaza. UN organizations, major humanitarian organizations, all have classified it as a genocide. So we also have to see how accountability works in these settings as well. And the British Medical Journal released this really important series about how the arms industry is profiting from the wars around the world that is affecting our health. So this is also a key global governance failure, but also a key challenge in global health as we move forward. I briefly want to talk about funding as well. There's a lot of attention in the US because USAID cuts were overnight. It was cruel. But we also have to realize all the high income countries have reduced their development assistance for health budget. And many of these countries are redirecting that money to defense. So this is a shift. As you become future leaders, you will have to tackle, are we going to turn inward, build walls, fortify our missiles, or are we going to invest in health and build that ability to work together better? So this is something we will be confronting in the future, right? As you can see, US used to dominate development assistance for global health, but from 2025 onwards, it's been dropping, and it's been affecting global health, not just countries that were receiving aid, but also organizations such as the WHO, Gavi, the Vaccine Alliance, Global Fund, and so on. So you can see in this chart how funding has gone down for many of these organizations. And African region has been hit hardest by the cuts because they used to get a lot of support in terms of this funding. And Africa has also been more exploited by colonialism, perhaps the most in terms of resource extraction, sometimes still ongoing, right? And you can see Malawi experiencing the greatest reduction in funding here. And I just put this article here. You can read this, how USAID cuts killed people, and that is the truth. I want to talk about epistemic justice because whatever we do, everything we speak on, everything we decide on is fashioned by the knowledge we receive and the knowledge we disseminate, right? So, the education you get, the ideas you have are fashioned by the knowledge that is created and is disseminated. So that is epistemic knowledge creation. And so the injustice of it means that we are kind of pushing towards one side, favoring one type of knowledge, or one concentrating on a certain type of perspective. So I highly recommend reading this book called The Foreign Gaze, which is a set of essays by Shea Abimbola, who is a global health professor at University of New South Wales. He also has an article on with the similar name. You can start with that and go to the book, right? So here is a bunch of articles that talk about epistemic injustice in global health, how journals prioritize, leave out knowledges from the global south, meaning countries that are not high income or countries that are not dominating the global health space. And the push now is to kind of make sure that we include, in authorship practices, research partnerships, academic writing, editorial practices, and so on, a more equitable approach to knowledge creation, right? You can look at, this is a research we did on PLOS Global Public Health. They have admirably committed to prioritizing epistemic justice. So we looked at the authorship of the front matter content of PLOS Global Public Health, and the results are reported in this article. Another factor that a lot of people from high income countries might not recognize is visa and passport inequities. So based on your visa, ability to get visa and the country you're born in and the passport that you have, this is something I experienced personally as a Sri Lankan. The ability for you to get to conferences, the time it takes, the cost it takes to get to these conferences or to go study somewhere is deeply affected. So we talk about how it affects global health knowledge exchange, but especially those who are less powerful. Even those who are powerful at high levels, whether it's at the WHO or at a university, are affected, but especially those who are less powerful are affected. So this is also contributing to epistemic injustice. In addition to visa and passport inequities, now with the rise of far-right movements, uh, global north is also becoming increasingly unsafe, right? You all have seen news about the riots that are happening in many of the high-income countries. The most recent one is, if I'm not mistaken, was in Ireland. But also just recently in South Africa, also there was an anti-immigrant rally as well. So this is a common theme that's happening, and it's creating unsafe environment. And in countries like the US, people who are working on equity, people who are working on LGBTQ rights are also targeted. So this is becoming a trend, and we have to think about where we hold global health meetings. And just want to highlight, when democracy is in crisis, public health suffers, right? This is a reality in America right now. If you can't post something, they will follow you to your hotel room. And this recently happened. An ICE member followed a person who publicly wrote a letter or commented on the government, found them in their vacation home and threatened it. So this is something that's happening right now. And the state of global democracy is tanking, but it is in our hands to, and there are good news that are happening, but also you can see more and more far right leaning leaders coming into power. And just want to highlight, taking America as a case study, when you attack on science and so on, and then the public policies, then the health suffers. And a lot of the times what happens is they shut down journalism, or they stop the news from getting out. And this is a failure in democracy. So I want to move towards the end of the conversation, reminding all of us that building a future needs a good future, a future that is healthy, a future that respects equity and human rights, requires imagination and community. That is where we all come from, right? Whether it's a professor from Monash, Malaysia, or whether it's a professor at McGill, or students from Vancouver or anywhere else in the world, right? We all need to come together and work together. So just want to start off saying that we also have had wins, right? So nobody thought the pandemic treaty would be passed. There's still the pathogen access and benefit sharing annex to be finalized. But, pandemic treaty was passed and it was a win for multilateralism and global health. And more wins will come with courage and with effort. And we are also at a crossroads. A lot of the global south, especially Africa CDC, they're taking the leadership in shifting the narrative, in shifting the leadership, in shifting the funding structures, and so on. So there's also an effort to say, okay, we are at this crisis, but let's use this as an opportunity to shift the status quo that we have inherited, right? So we wrote this piece, Madhu, myself, and Catherine Kebutungi, on shifting power in global health that will require leadership by the global south and allyship in the global north. You can also listen to the podcast related to this as well. Something we said is that the global south needs to lead, so governments need to invest more, funders and donors need to increase investment without relying on global north funders, and academic institutions need to take more agency, and so on. We also highlighted allyship by the global north. So, particular to this, audience, I would say, as you go into academic institutions in your next career, think about building equitable and bidirectional partnerships. As you learn, ask your professors, are these the things that are happening? If you're writing, make sure it's open access, and that everybody from around the world can access these articles or things that you're putting out, right? And always recognize that international students do not have the same privileges that the students from high income countries might have, and then see how you can support them. Challenge the structures always to say we need to center equity around these factors, but also at larger levels, right? Where, challenge your government, challenge funders and donors, and say equity needs to be central if we are to have a more healthy society. And I want to finish this by saying that we are, at a time where everything is polarized, and many of the conversations also intentionally polarize us, including our algorithms in Instagram or TikTok or Twitter or whatever the social media that you're consuming. So be aware of that polarization that's happening intentionally, right? Know that Meta is not there to give you the news in a neutral way, right? Know that it's peddling things that are affecting your mind and fashioning your mind, and putting you in a fishbowl, or just the news that you want to see that might make you more angrier towards the other side. So in this piece, which I wrote, this was an invited editorial I wrote to McGill Global Health McGill Journal of Global Health. We asked our own community at McGill at the time to recognize this concept called othering, meaning that othering is basically weaponizing our differences against each other, right? So be aware of that. And by being aware of that, go read more about othering, the concept, the philosophy behind it, and see how it is weaponized against us and how it does not help to build solutions. And we also offer three main considerations. First, center kindness in our engagements in anti-othering. Having a conversation in my advocacy work, whether it's in conflict zones, whether it's in human rights, whether it's in global health policy rooms, having a conversation, getting to know the person, and then talking about the issue has had a lot more impact than just putting out policy briefs or shouting from rooftops or naming and shaming. So the first step needs to center kindness in othering. This does not mean that you give up on accountability, right? You hold people accountable, but you don't have to do it in a way that compromises your kindness. Second is a commitment to listening and unlearning. Throughout your life, you will have to listen and unlearn. There will be a lot more things that you don't know than you know. So it's really, really important sometimes to be quiet and listen to the person and unlearn. Whether it's about racial differences, gender differences, any other differences in the world, right? Finally, as I have been kind of phrasing throughout this talk, I asked you all to strongly consider becoming an active advocate. In this moment, doing scientific research passively, not recognizing how far-right movements are dismantling our social structures, pitting ourselves against each other, is a harm that we're doing to ourselves. So commit to becoming an active advocate. You can contribute in many ways. You don't have to be the most outspoken person, right? If you have your skill, see how your skill can contribute to this effort and combat anti-othering across the board. With that, I'm gonna stop here. You have my contacts here. You can reach out to me anytime, and I'll be happy to chat and support you in any way that I can. I want to wrap up asking you all a question. I hope this Slido works. Can you all, at this end of the talk, tell me how do you hope to contribute to the future of global health?
Yes, thank you so much, Dr. Bandera, for that very eye-opening presentation. And all of those in the audience, feel free to visit slido.com, enter the code 5683784 to contribute to the discussion. But right now, we will open up our Q&A period. So, Dr. Bandera, I'm just going to open up the floor by asking, when we talk about shifting power in global health, are we genuinely redistributing authority, or are we simply rebranding existing hierarchies in a more palatable language?
Oh, that's a great question, Jonathan. So we just wrote this piece on how WHO and a lot of these multilaterals have created this committee or task force to reform global health, which does exactly what you said, which just rebrands the hierarchies. So, something to be conscious of is that power, those in power will never give up power willingly, right? A lot of the times, it takes effort to take the power from the powerful. So, something as we go forward is that we have to center shifting of the structures, looking at the structures, see where they went wrong, and shifting those structures in order to shift the status quo. So, this is what we have said in that piece we wrote about claiming the room, right? And this has to be a continuous effort. This has to include introspection on our side, thinking that am I perpetuating, the same old? Also, making sure that we hold our leaders, including our own friends and professors and heads of organizations accountable as well. Yeah.
Yeah.
Anyone else
Thank you
want?
for that response. Yeah, I mean, this is such an insightful presentation. You did just talk about a lot of the funding does come from Western nations like the US, and near the end of your presentation, you talked about like the dismantling of programs like USAID. Um, my question is, if you're no longer funding the research of these diseases that disproportionately affect like sub-Saharan Africa, and you're canceling vaccine development and testing in these areas, but like these diseases like Ebola and malaria don't care about borders, does that also jeopardize the health of citizens in Western nations too?
Um, Well, obviously, I mean, one of the things we learn in epidemiology is that, like you said, this is a do not know borders, and it's essential that we recognize that. But the fact that diseases do not know borders haven't stopped politicians from prioritizing their own countries, and they think by adding travel bans or like creating this centers of quarantine in Kenya instead of to just rope out the U.S. citizens who are affected is enough, right? Like so, that's not enough, and that diseases always find a way across borders. But in the immediate obviously the disruption of funding, of not caring about global threats is a big problem, right? But we also need to move away on dependency from high income countries. So one of the things is to have have ownership of your region or your country. So one of the things that hopefully is being pushed towards, this is happening right now through movements such as Accra Reset, is to own your own change, right? Own change you want to make, whether it's in the African region, whether it's in the Southeast Asian region, and build funds and get funding and then create your own agenda as opposed to being dependent too much on places like the US, because as we saw, the leadership can cut funding overnight and have no consequences of the deaths and the destruction that they cause. And Canada is no better, by the way. They also reduce funding to global health this budget. You all should go read up on the advocacy around that and how it affects. And so there's lobbying to be done around that as well
There
for
is,
Canada.
and we have diverted a lot of that funding, as you said, like to military expenditures too,
Mhm.
such as right, like especially with the U.S. no longer funding NATO and having to meet like 2% GDP targets, right?
Yeah, absolutely. And Canada is scared, no? Like because now countries US is kind of saying, okay, we are using what do you call hard power or strong man approach to politics. So then they also have to be ready for that type of conflict as well. So when one country goes berserk, especially the ones with military power, the rest of the world also kind of follows.
Yeah.
Sure. I'm just going to follow up on that. So what would a genuinely equitable global health funding model look like if designed from ground up today?
A global health equitable funding model, we talk about this in our paper on the shifting power paper. I think the biggest thing is that like governments needs to invest more in research and health. So there is a percentage target set by the WHO saying you have to meet, I think it's 5% or 4%, but of your budget towards health. But we also, especially as global South countries, need to invest in our research, right? Like a lot of the research funding, if you look at, come from or used to come from NIH, but come from high income countries, whether it's National Institutes of Health in the US, CIHR, Canadian Institutes of Health Research, or other European countries. So we need to shift that model as well. So, because when a government, let's say I'm from Sri Lanka, if the Sri Lankan government funds research, they're going to fund research that is relevant to them, right? And so it will not be dictated by, interests of the US. So if US is funding, they probably might think, okay, how do we stop infectious diseases from spreading that could come from Sri Lanka that will affect our population? There might be others as well to achieve global goals, but from a political perspective, that would be their interest, right? They could sell that in the political stage. But if your own government is funding your research, then that priority changes. So that's one. The other thing is we need to have multilateralism. We cannot do away with that because a lot of the challenges that I spoke about, whether it's wars, whether it's climate crisis, whether it's outbreaks, these are global crises, right? Without working with each other, we will never solve these problems. So then we have to recognize, okay, how do we build these funding models that are equitably distributed, and how do we create governance systems that does not just prioritize high income country agendas, right? How do we look at Gates Foundation and see, okay, can we move this agenda to represent more of the challenges, or make it more equitable than the foundation itself dictating the terms, right? They do prioritize many of the challenges around the world, but how do we democratize the process of agenda setting? So these are the ways in which we can prioritize. And speaking to civil society, speaking to communities, doing research around, highlighting the perspectives of communities are important. So that's one. I think that would be a way to democratize. The other way would be to also strengthen the implementations of tools such as, the pandemic treaty or WHO FCTC on tobacco control to make sure that we have norms and policies to follow up our intentions, right? So, one of my researchers recently looked at how the perspectives on the WHO FCTC in Zimbabwe. And so, highlighting those perspectives is important as we are going to build more policies as well. Okay, I'll stop there.
Yeah, that's very interesting indeed. I do want to read your paper after this webinar to fully get my brain soaked with all of this very intellectually stimulating and very important, health policies that we have to implement. One of my questions was you talked about the vaccine inequities.
Mhm.
However, because patent protections and intellectual property rights usually limit where and how these vaccines can be produced, and which has allowed for Western companies to continue possessing like a monopoly over these vaccines, how can we actually ensure a fair distribution of these vaccines, especially to the global south?
Yeah, so this has been a challenge since, I mean, AIDS crisis, right? South African. So in South Africa, there's a huge movement along with Brazil to get generic drugs of antiretrovirals at the time, and we are still facing this challenge. There is this declaration called the Doha Declaration that says that in a moment of public health crisis, you can produce drugs to support your and waive some of the patent regulations or protections around it to produce these drugs for that public health crisis. But as you saw in COVID-19, that was not used and that was not being able to use because HICs and pharma blocked it. So this is why things like pandemic treaty is really, really important because then you set, the pathogen access benefit sharing annexure in particular is really, really important because then you set these ground rules or guidance around how we are going to equitably distribute, produce, and response during a pandemic, and also prepare for things like that. But in addition to that, I think we need to, I think Africa CDC is already investing on regional manufacturing. So you build manufacturing capacity in your own region, in your own countries, so you don't have to depend on these Modernas and other pharmaceuticals to give you the vaccine. Did you all know that Moderna walked away with a 400 billion profit during COVID-19? And so this is the kind of this is the kind of sort of exploitation that keeps happening, especially around pharma. Not all pharma is bad, but still, majority. It's a profit-oriented model, so they're looking for profit. Okay, so I also want to stop, not the Q&A necessarily, but I know there's a few people around the room. So I want to go around and ask what your goals are in terms of global health, and what you hope to do. This is not a like a difficult question or to put you on the spot, but let's go around the table.
Matthew, do you wanna start us off?
Sure. I think in terms of health and global health, I think the first thing is obviously education. I think people need to know about health policy and just the types of diseases that are spreading in different parts of the world and the equity challenges. And I think the first step is to do things such as like run webinars and just raise awareness about these issues. And then the next step is about empathy, right? Like when people care about this, they'll naturally be inclined to do things such as, become an activist or like protest, or even do things such as like vote for politicians or pressure politicians who actually support these policies.
Okay. And what do you hope to do in your future career, Matthew? Do you know?
I'm thinking of studying political science and public policy. And so I'm going to be at the intersection of healthcare and policy. So I'm going to be learning a lot about, health systems and health challenges, indeed.
Brilliant. Okay, Jonathan.
Yeah, thank you, Matthew. It's going to be pretty hard to follow up from Matthew after what he just said. But yeah, I don't know. For me, global health has I kind of found global health from a very young age. I've always been much of a more action-oriented person. I know a lot of people like to do things through like advocacy and like politics. These are absolutely great things. But as for me, I feel like global health equity really starts from individual people. If we have more people who want to join the healthcare sector simply for their passion or just the love of the game, I feel like having more people who are willing to put themselves out there for humanitarian projects, organizations such as Doctors Without Borders. These are great organizations that have done so much to bring healthcare to more people. As for me, I want to be a dental surgeon in the future. So I feel like, I've done several projects abroad in Peru and Kenya. I've personally witnessed what happens when, structures fail people. And for me, I want to, eventually maybe work for Doctors Without Borders someday. Dental health is very important. It plays a huge impact on people's lives. So that's kind of something I really want to dedicate a lot of my life to.
Okay, brilliant. Yeah, it's a great organization. And as you gain your foreign or different experiences, ensure that the partnerships are equitable and parachute research and parachute practicums are also not being done, right? I'm sure you're thinking about that given that you're organizing these webinars and so on.
Of course.
Jury?
Hi, so I think that if we're looking at dismantling structures and shifting power, we have to be like more real and open about it. So it can't just be about like having like conversations about how we're going to fix the future, but actually like having real discussions about it and ensuring that we are able to have like adequate conversations and actually come up with ideas so that everyone's feeling that they're being taken account into, and also that we're like everyone has a say in the global health scene.
Okay. No, that's good. I think we need to have conversations that are um, that would perhaps make us uncomfortable, right? So real discussions, and to see how can we incorporate ideas that we might not necessarily agree with. Sometimes, we may all see the problem, but we all might come at it from a different angle. So we need to have the capacity to kind of incorporate everybody's solutions and build collective solutions. Brilliant. Kira?
Think so recently I went to the Canada-wide science fair and I was exposed to a lot of people trying to promote better healthcare access for low-income nations. So I feel like building on some of the youth ideas and actually trying to implement that into lower income nations can definitely improve equitable access.
Okay. Something to think about, really necessary to build these partnerships and collaborations. But global health is not just about helping low and middle income countries, right? So something to think about is disparities in our own society. So there's a paper called Local is Global. So there's a concept called Global now, which is global health in your local community. And there's a paper by Madhu actually around how we can shift our education to think about these disparities in our own neighborhoods. So think about disparities on our own neighborhoods as well, right? In Canada, one of the biggest discriminations and disparities is around Indigenous communities. So how can we shift that narrative? How can we support those communities? And in addition, and collectively, we should also make sure globally we are all achieving health goals. Thank you, Kira. Chris, nice t-shirt. I saw your t-shirt earlier. Nice t-shirt.
Thank you. Yeah, I think something I'd be interested in would be underlining the global and global health, because I feel like it's all about globalization, like we're each other's keepers. And I feel like at the international level, especially lately with the rise of right-wing populism across Western Europe and across high-income nations, there's been this mentality of individualism that's been rejuvenated. Like this idea that like we can withdraw from World Health Organizations, that we have to like set a trend and look out for ourselves before each other. And I think that goes contrary to what global health is. And I want to study international relations and history, and I want to work at like international agency. And I think what I look forward is this idea of promoting links between different nations in a way that doesn't sustain neocolonialism, but rather like is an equitable dynamic that ensures equal distribution of resources across countries and doesn't just go into like one country as opposed to the broader global community.
Brilliant. Yeah, I think yeah, this is the big goal we are all going for, right? About distribution and making sure that equity is at the center of how we operationalize global health. Something to think about is, I mean, these are important goals and we should aim for those, but how can we start with our own communities? Like, so you guys doing this webinar is amazing, right? And just being in this table itself, whether you're going to remember 5 minutes of my talk, it's still important, right? Like, um, so start thinking about your own privilege in some ways, but also how can you also then, extend this understanding to your community. So the way you interact with your community, your day to day, and also how you support your community. Great ideas around the table. I appreciate the thoughtfulness, and I hope all of you will become leaders. And I know, I mean, just from seeing all of you, you will be. But when you're becoming leaders in your fields, remember the power differentials, remember the structures of society. Don't forget, I would say sometimes we tend to forget these things as we try to also achieve our personal goals. So some balance is needed as you try to achieve your own goals as well. That would be my suggestion.
Yeah, and thank you, Christopher, for that very insightful response. Just as we kind of wrap up here, Dr. Bandera, what would success look like 10 to 15 years from now if allyship and power redistribution were taken seriously, and what signs would indicate that we've not been successful in that?
Okay. In terms of success, I think for me, it would look like a world where um, we can, live and work anywhere we want without restrictions and without being discriminated against. And then also within our own communities, a lot more reduced discrimination and health outcomes reflecting that, right? So if you look at COVID-19, a lot of the people who were affected, if you take New York, were African American communities, right? Like so, and when crisis hit Sri Lanka, whether it's economic crisis, the poorer, the informal economy, people were affected. So my hope is that we reduce these disparities, both economic and social, recognizing that racial disparities and gender disparities has a direct connection to our economic and health well-being. So this being prioritized. So in a world, hopefully all of us will have better economic standing and health. And a world that has not succeeded we'll have a lot more wars. We'll have a lot more outbreaks. Bunch of islands, including Sri Lanka, will probably be submerged, and we will still be talking about silver bullet solutions like Elon Musk saying, "Okay, robotics can solve food problems and health problems," and it will just be at the Twitter level rather than at the actual level of implementation. That will be a failed world, and the rich will have their yachts and bunkers or whatever the technology they need to survive many of the crises, but in the end, they will also have to, it will be existential. So everybody will be affected. That's a very grim world, which I hope doesn't come to pass. Yeah.
Absolutely. One last
Absolutely.
question for you. Sorry, Matthew, go ahead.
Oh, I was just saying, if anyone else had any other questions before we wrap up today's session, please feel free to just unmute and, yeah.
Yeah, you all can ask me anything, whether it's career, whether it's my experience, anything at all. Like as I said, I was born and grew up in Sri Lanka. I've studied in US, Canada, worked around the world, and now I'm in Malaysia trying to do this work in global health, in global South, as I have written about. So yeah, any questions?
Yeah.
Yeah, I think I have one more question actually.
Yeah.
So my question is, so at the very end, he talked about robotics and like Twitter level solutions. And when I thought about that, I instantly thought of like AI. And in its
Mm-hmm.
present capacity, AI has been sort of bourgeoisified and it's been used for like capitalist companies like Elon Musk to sort of dictate like economic policy and further their profits. So I guess my question is, do you believe AI and I guess that field as a whole represents like a positive potential in the field of global healthcare? Or do you think its capacity is more like restricted to being like another new colonial instrument that benefits the global north as opposed to equitable redistribution?
Great question. So I think anything that whether it's technology or other is a tool, right? So it matters how we use it. I don't think AI as is very ethical because of how they, take the data, the amount of water that's needed to sustain them. So we need to find solutions that doesn't kill our planet and also that perpetuates these stigmas and other social hierarchies that we've had. But on the other hand, I think if there are ways it can help make the health sector efficient or do research in a more efficient way. So then we have to see, okay, how do we use this tool and recognize its cons, like as in its drawbacks, and then also the positives it brings and have that balance. So right now, what's happening is that it's being romanticized. Everybody's talking about it. And whenever you talk about the downside of it, whether it's the environmental impact or ethical issues, people are like, oh, you're against progress. We have to take both sides seriously and try to not make it a tool that will just serve powerful and rich people.
If you and me were to die tomorrow, what would be one last message you would want to leave to the world?
Uh, so I work in global health and it can be quite depressing, especially right now. My message would be, it's a very non-global health message, honestly. My message will be to live your life with joy, right? Do this work very diligently. Like I write, I advocate, I stay up at night to do this work. Madhu and I just wrapped, the Reimagining Global Health course, which was like a week-long intensive online course, which required me to stay up every night. I do this work diligently, but I also highly, highly suggest everybody to center joy and what brings happiness to you, because that itself is also really important for you all to keep going, right? Like for you all to enjoy life. Academic achievements or career achievements, changing the world is just one aspect of your life. Also live your life with joy. So if you're going to die tomorrow, make sure you've had a good day today, right? Like so, that will be my message. Yeah.
Some amazing advice. Matthew, any last remarks?
I mean, thank you so much, Dr. Bandara, for joining us today and for helping us think more deeply about what it really means to shift power and leadership to local communities. I think you really left us with the lasting impression that healthcare is not just it's not just something technical, but it's something that's deeply political. You talked about, armed conflict, about climate change, about access to different technologies and like vaccines, about how disease is rampant, vaccine inequity. They're all shaped by who controls these resources and also who gets to receive this knowledge in terms of accessing conferences and things like whose research gets published. So thank you for a great talk about, I guess, the colonial histories of healthcare, about a lot of the ongoing geopolitical interests of these Western colonial actors. But thank you for also showing us that that change is possible too, and we can each take steps from our own lives, from the local initiatives that we can take to show that change is possible in the future, and that we can all be healthcare leaders of our own. So yeah, thanks for joining us, and thank you for everyone else to being a part of this conversation.
Brilliant. Thank you all. I have to say this, I don't know how many times you all hear this. This is inspiring that you're starting this at this level. It's really, really necessary for us to do this work continuously at every level as you hopefully progress through your career. So keep that inspiration. Know that I am inspired by you all, and all of us are. So keep going.